Hello and welcome everyone. Today's presentation is on the European Network for ICU-related respiratory infections. It is a multinational prospective cohort study published in Intensive Care Medicine last week. This study basically focuses on the diagnosis, occurrence rate, and the clinical outcomes of ventilator-associated pneumonia in ICU patients. Recent data indicate that not all ICU patients with LRTI have the same clinical characteristics and outcomes. Now, other less known conditions like ventilator associated tracheobronchitis, hospital acute pneumonia are also very prevalent in the ICU settings. Most data on this condition come from clinical trials and observational data sets, which may not accurately represent a real world scenario. The admission criteria for ICUs vary from country to country and from ICU to ICU. Some ward patients may be more susceptible to hospital-specific pathogens due to their longer stays. The European network aims to study the clinical outcome of this nosocomial LRTI in ICU patients. The study hypothesizes that the patients with ventilator HAP would have the highest mortality rates. Now, the primary goal is to report on the clinical characteristics, microbiology, and the clinical outcome of the nosocomial LRTI in ICUs using a prospective multinational cohort. Now, this study was a prospective multicentric observational cohort study conducted in 28 ICUs across 13 countries in Europe and Latin America from the May 9th, 2016 to August 16, 2019. The study focused on patients aged more than 18 years and who developed a LRTI either 48 hours after ICU admission or during any point of the ICU stay. Follow-up was conducted until hospital discharge, and the study is the primary analysis of the ENIRRI study. Eligibility criteria, as I said, was 18 years and older, patients admitted to the ICU, and nosocomial LRTI. Readmission patients were excluded. Data collected was demographic, comorbidities, illness time course, treatment, lab and microbiological data, ICU complications, and outcomes. Disease severity was assessed by SAPS-2 and organ failure by SOFA. Ventilator management, treatment, and microbiological assessment were not standardized and were left to the discretion of the attending clinician. Now, coming to the definition, they use the CPIS scoring based on temperature, leukocyte, and the secretions to define nosocomial LRTI. Now, they classified, once the diagnosis of LRTI is made, they classified it into 5 categories. The first is HAP, that is a LRTI acquired outside the ICU at least 48 hours after the admission into the hospital. However, the patient did not need a ventilator after coming to the ICU. The ventilator HAP is LRTI, which was 48 hours after hospital admission, but the patient comes to the ICU and gets attached to the ventilator. Next is ICU HAP. These are patients who are admitted but develop a pneumonia 48 hours after ICU admission. However, at no point they require a ventilatory support. VAP is patients who are on ventilator and after 48 hours they develop a new pneumonia. Lastly is VAT, in which the patient develops symptoms of LRTI after the intubation. However, in the chest X-ray, no progressive infiltrates are seen. Now, the primary objective was to determine the clinical laboratory characteristics, microbiological features, and outcomes of this LRTI in critically ill patients. The secondary aim was to describe the clinical impact of these entities and compare the differences between these study groups. The statistical analysis was done by SAPS-2 and various tests like chi-square, Fisher's student t-test, ANOVA were used for the statistical analysis. Now, coming to the results, 1062 patients were reported, 2 got excluded because of missing data. Out of that, 1060 were included in the analysis. Out of this, 52% developed ventilator associated pneumonia, that is 556. VAT was 15%, that is 160 patients. HAP, that is hospital acquired pneumonia, was 14.3%, that is 152. ICU HAP was 9%, that is 98 patients. And ventilator requiring HAP was 8.9%, that is 94% patients. If grossly you will see, you can see a significantly higher mortality in this particular subgroup, that is the ventilator HAP. Okay, so coming now next to the ICU types, most of the patients were coming from the general ICU, that is this green, which is 47.6%, followed by medical, which is 32%. Other ICUs like neuro ICU, surgical ICU, trauma, and burn units also contributed some part of the study. If you look at the severity index, it was more or less similar in all the groups, except the ventilator HAP patients who had a slightly severe scoring as well as more organ failure compared to all the other groups. Now, if we look in terms of the microbiological profile, a huge percentage of the patient, that is the highest, was Pseudomonas. Here you can see in the brown, followed by Acinetobacter and Klebsiella. Now, this is the same thing depicted in a table. So, if you look at the overall cohort, Acinetobacter was 9%, Klebsiella was 10%, and Pseudomonas was 15%. Now, if we look in terms of the antibiotic resistance, in antibiotic resistance, if you look at the overall full cohort, then MDR was seen in 12%, which is very high, ESBL in 7%, carbapenem resistance in 5%, XDR 4%, and PDR was 0.7%. And so this is the other group differentiations. So as you can see, the overall incidence of MDR was very, very high. Now finally, the major outcomes, that is the complication rates, again they were significantly more in the ventilator HAP group, where you can see here the AKI was 17%, ARDS was 34%, which was significantly higher compared to all the other groups. Septic shock was 40%, multi-organ failure was 17%, and again a significantly reduced clinical cure rate and higher treatment failure, with, as we have already seen, higher hospital as well as ICU mortality rates. Even the length of stay was less, but this length of stay less was primarily because the patient died early. So the limitations are, it is a multi-centered, multinational study but lack representation from Scandinavian countries, and since they have a lower resistance rate, probably that could have reduced, so it doesn't really show the incidence of entire Europe. However, it also doesn't show the incidence in other continents like in Asia or North America. The diagnosis and treatment was not standardized, which could have affected the other factors, and most of the fungus and viruses were not tested. Study was limited to ICU admitted patients. The patients, like a patient with hospital acquired pneumonia who is getting treated in the ward, was not a part of this particular study. Now, despite limitation, the study does offer valuable insight into the current clinical practice, the proportion of different types of nosocomial infections, and subdividing them into all these groups probably would help us find a subtype or a subgroup of patients who may be more aggressively treated for better outcome. For example, here we found that it showed that in among these various types of nosocomial pneumonia, the ventilator had the highest mortality rate. So we need to find out why this patient group is actually having this high mortality rate, and we must analyze in future trials what are the reasons which are attributing to this high mortality rates. Now again, as we have already seen, MDR was also very common in most of the patient groups, probably leading to significant mortality risks. Thank you for your patience,